Hello, and welcome to our review of the lupus literature from December. We record these podcasts for you every month, so you will always be able to keep up to date on the latest literature and expert opinions. My name is Maria Dall'Era. I'm professor of medicine and chief of the Division of Rheumatology at the University of California, San Francisco. And today, I'm thrilled to be joined by Dr. Brad Rovin, who is the Lee A. Hebert Professor of Nephrology and the medical director at Ohio State University Clinical Research Management Institute in Columbus, Ohio. Welcome, Brad.
Hi, Maria. It's really good to be here with you today.
Great to be with you. I'm looking forward to our discussion. We'll be discussing one manuscript and then also discussing at a high level the newly developed and released ACR guidelines for the screening, treatment, and management of lupus nephritis.
So the publication we're going to review today is, of course, your publication that came out recently. So Maria, why don't you start us off telling about what you worked on and what your interpretation of the data are.
Great, thank you. I would love to. This is a paper in which we conducted a propensity score matched analysis of two groups of participants. The first group were participants that took part in the ALMS trial, the Espriva Lupus Management Trial, which, as you remember, took place more than a decade ago. And in that trial, there were two phases. There was an induction phase and then a maintenance phase. And we're just going to be talking about the induction phase today, in which participants with class 3, 4, or pure class 5 lupus nephritis were randomized to either high-dose glucocorticoids plus high-dose mycophenolate at 3 grams a day, or high-dose glucocorticoids and monthly pulse IV cyclophosphamide. And the primary endpoint of the induction phase was at 6 months. We're taking those participants and comparing them to participants that took part in the phase 2 Voclosporin trial, the AURA-LV, and the phase 3 Voclosporin trial, the AURORA-1. And we're trying to compare safety and efficacy in those populations. And because we don't have a randomized controlled trial to directly compare those populations, we conducted a propensity score matched analysis in which we matched participants from the ALMS induction, as I just mentioned, to the voclosporin-based regimens in the trials that I just mentioned. And we matched on a variety of covariates, including age, duration of lupus nephritis, duration of lupus, complement levels, creatinine, double-stranded DNA, eGFR, proteinuria, biopsy class, geographical region, and sex, in a way to try to make the two populations as equivalent as possible. And then we looked at safety and efficacy in 3 and 6 months time points, because remember, ALMS only went out to 6 months. And the overarching idea was the following. How does a voclosporin-based triple immunosuppressive regimen, in which voclosporin was used in combination with a lower dose glucocorticoid, remember we started in that trial after pulse methylprednisolone, the starting oral dose of glucocorticoid was 25 milligrams a day, and then a rapid taper down to 2.5 milligrams a day by week 16. How does that compare to conventional high-dose immunosuppression that was used in ALMS? So that was the overarching idea. And before we get to the results, did you have any questions about the methodology, Dr. Rovin?
So just, for the audience, I think it's important to realize that this propensity matching is a well-described statistical technique that allows us to compare trials from different eras. The one real issue is, of course, it's not ever going to be as good as a head-to-head trial, but we probably aren't going to see a head-to-head trial with the newly approved medication triple therapy compared to dual therapy. I think the other thing that I would point out, or let you, sort of think about or discuss, is a little bit of a disadvantage. I'm not advocating one or the other, but a little bit of a disadvantage to the ALMS data because we only did the trial for 6 months. And of course, that was in the era when we really didn't know that the length of the trials should be longer, right? I mean, the newer trials are now looking at 2 years of data. So those are a couple of little caveats that I think are important to keep in mind for the audience, right?
Absolutely. I think those are very important points that you make. And I think in terms of the efficacy that we'll talk about, as you said, we only have that 6-month time point because that's as far out as the induction phase of ALMS went. But I think what we can look at are changes in proteinuria during that time, which we know are associated with long-term outcome. But it's not as good, I agree, as being able to follow the patients out to 2 years where we can really understand what the kidney outcomes are.
Yeah, no, absolutely. So why don't you tell us what the data were? I'm excited.
Okay. So we looked at safety and efficacy, and the hypothesis going in was that the triple immunosuppressive regimen using voclosporin, in which the doses of glucocorticoids were significantly lower and the dose of mycophenolate mofetil was lower. Remember, it was 2 grams in the voclosporin trials versus 3 in ALMS. The hypothesis is that safety would be better in the voclosporin groups and efficacy would not be compromised. At least there would be equivalent efficacy. That was the hypothesis. And that is what was found. So when you look at AEs, adverse events, across the board, overall, in the general categories of adverse events, there were more adverse events in the participants that took part in the ALMS trial versus the voclosporin trials. And the AEs are ones that you would expect based upon the known toxicities of high-dose mycophenolate mofetil in terms of, gastrointestinal side effects, for example. Those were well described. There was not a difference in serious AEs between the two groups. There was an imbalance in terms of more AEs in the domain of eGFR decreased and hypertension, for example, in the voclosporin-based groups, and those are expected based upon the mechanism of action of a calcineurin inhibitor. So that was one slight difference. But as you know, Brad, from a lot of the work that you've done, you can talk about this, that we would expect a small decline in eGFR in the range of maybe 2 to 3 in the first 4 weeks of starting a calcineurin inhibitor, like, for instance, like voclosporin, that was seen. But then we saw stabilization of eGFR over the course of time. It didn't continue to decline. So a small dip that we would just expect, but then stabilization over the course of the trial.
And that's exactly right. The calcineurin inhibitors have many effects, not the least of which is a hemodynamic effect on glomerular blood flow, and having a small decline that stabilizes of GFR really, and is reversible upon discontinuation, really does not set off red flags for us. Now, if the GFR continued to decline, that would be a different issue. But the idea is, of course, if you change glomerular blood flow and you reduce glomerular hyperfiltration or hypertension, you actually protect the glomeruli. So despite a lower GFR, you are probably imparting some nephroprotection. So I think to be expected and not to be overly concerned about, unless it was, of course, a big fall in GFR, then you would have to recalibrate and use a different dose.
Excellent. And now moving on to efficacy, as one might expect, based upon the fact that voclosporin calcineurin inhibitors have multiple effects on the kidney, and one of which is fairly rapid reduction in proteinuria, right? Based upon, and we can, and Brad can talk about this and elaborate on this in more detail, but based upon the action on the podocyte directly, not surprisingly, we saw a more rapid reduction in proteinuria in the voclosporin group compared to the ALMS group. So just to give some numbers here, for example, we looked at metrics such as a UPCR reduction of at least 25% at 3 months, a UPCR reduction of at least 50% at 6 months, and then a UPCR reaching a level of less than equal to 0.5 at 6 months. And these were metrics that we took from the updated EULAR guidelines for the treatment recommendations of lupus nephritis as being targets that we should be aiming for as we treat our patients initially for lupus nephritis. And not surprisingly, we saw better efficacy in the voclosporin group, so greater reductions of proteinuria at 25% at 3 months, 50% at 6 months, and then reaching that threshold of 0.5 at 6 months. Greater reductions and more rapid reductions in proteinuria in the voclosporin groups. And the extrapolation here is that because we know early reduction in proteinuria is associated with better long-term kidney outcomes, we hypothesized then that because we are seeing earlier reductions in proteinuria in the voclosporin group, that would portend better outcomes. But of course, we're not showing that in this particular manuscript.
But Maria, I want to give you some credit here. I think you were one of the first people who, looking at an analysis of the ALMS data, suggested that if we do see a decline in proteinuria of 25% during the first 2 to 3 months, this would be a very good indicator going forward that we were on the right track in treating our patients. They were likely to respond to the therapy that we have had them on. And I actually use that all the time in my care of patients because it gives me a goal in the first 3 months, 2 months of therapy to say, well, if my patient isn't meeting this reduction in proteinuria, then I have to worry that maybe I need to think about a different medication. So again, kudos to you for that paper. And I know that's an older paper of yours, but I think it's stood the test of time. I would like you to comment. I was surprised when I looked at your data here at the dual therapies, the low-dose cyclophosphamide or the just high-dose mycophenolate with steroid. They didn't do as well as voclosporin, of course, in terms of the 25% reduction in proteinuria at 3 months, but they didn't do so badly, did they?
Yeah, I agree. It's very interesting. And as I contemplate that question, I wonder, I would love to hear your thoughts. I wonder if a large part of that are the high dose glucocorticoids that were used, perhaps.
Mhm.
In the traditional, back in the day when ALMS was designed, interestingly, as you know, IV glucocorticoids were not allowed within 2 weeks of randomization, which was different from the voclosporin trials, right, in which IV glucocorticoids were used up front. But the starting oral dose in ALMS was a mg per kg, 60 milligrams a day. And there was a much slower taper, I believe, down to 10 milligrams a day by week 16. And people just kind of sat there. And so the cumulative dose of glucocorticoids was much higher in ALMS than in the voclosporin trials. And in fact, I should have mentioned that earlier, that we clearly saw differences over those 6 months, comparing the two groups, ALMS and the voclosporin trials, differences with cumulative glucocorticoid dose and then mean daily oral dose. And I wonder, do you think that might have contributed to what you were?
I think it could, and I think one of the things, and we'll talk about this in just a minute when we talk about the new ACR guideline recommendations for the initial treatment of patients with lupus nephritis. One of the biggest problems I believe for my patients anyway, and I know you agree, is the steroid side effects are just
Yes.
overwhelming for these young folks who really, prior to having lupus, had not been sick. And I think that, you know, there's no doubt that glucocorticoids are beneficial, but the fact that we can reduce glucocorticoids, maybe add another drug, which adds another dimension to the treatment that I think is really important, as you alluded to, direct effects on the podocyte from the calcineurin inhibitor, but also allows us to really reduce the steroid dosing is beneficial to the patient because not only are there the acute effects of steroids that we see, acne and weight gain, et cetera. But then you put the patient subject to long-term side effects of bone health and perhaps, metabolic disorders, diabetes comes to mind. So
Yes.
I like the trade-off, and I think the trade-off is favorable for the patient. And I'll just address the one thing you brought up before. Don't forget that, as Maria said, the voclosporin and other calcineurin inhibitors act at multiple sites in protecting the kidney. And one of the things that it does is keep the podocyte cytoskeleton intact and prevents the degradation of synaptopodin, a critical element to keeping the foot processes and the glomerular filtration barrier intact. So I think these are very beneficial effects, especially early on in lupus, because when we diagnose, this is the time of maximum damage because it's apparent clinically.
Excellent. No, those are excellent points. Thank you. So I think that these are interesting data. The other thing that I'll just say before we close out this paper and move on to talk about how the findings in this, I think in this paper, nicely correlate with what we'll be talking about in terms of the guidelines and the triple immunosuppressive regimen. But I think, when the phase two voclosporin trial, the Aura LV, was published, and then the Aurora 1, which is the phase three trial, was published. Some people, I think, rightfully said, when you're comparing this triple immunosuppressive therapy to the comparator, and the comparator was the low dose glucocorticoid plus low dose MMF, I think people looked at those data and said, well, yes, you're showing that the triple immunosuppressive regimen is better than perhaps a quote unquote substandard regimen of low dose MMF and low dose glucocorticoids. So of course, you're going to see improvement there. And I think that that was one of the intents as well of this sort of analysis, was to compare the triple immunosuppressive regimen to a more standard conventional high dose regimen, which some people might consider to be more of a reasonable comparison.
And you actually did, you along these same lines, you had a paper out a few years ago that actually looked at the control arm and compared the control arm of the voclosporin trials, the phase two anyway, to the ALMS, and comparing the low dose protocol to the higher dose, and just really briefly talk about those findings.
Yeah, so exactly. Several years ago, 2019, we published kind of an initial propensity score matched analysis looking at a smaller number of patients. I think back then it was 63 matched pairs. And we looked at the control arm of the Aura LV, which is the phase two voclosporin, the control arm being low dose MMF at 2 grams a day plus low dose glucocorticoids. And we compared that to the traditional regimens used in ALMS. And as you said, we saw similar efficacy. So there was no kind of detriment in terms of efficacy with the lower dose group, and we saw a better safety. So very interesting, as you said. So that was kind of the initial trial that then led to this. And back in that 2019 publication, we grouped all of the ALMS patients were in one group. Whereas I think one of the beneficial aspects of this paper from today is we were able to stratify out the IVC group and the MMF group within ALMS. And so we could actually look at those two subgroups separately and look to see safety and efficacy in the IVC arm, the MMF arm, compared to the voclosporin arm. So that was the other, I think, advancement in this particular study. But that's absolutely right. We looked at this question initially back then with a smaller sample size, and then took it to the next level with this publication.
And what you show is better efficacy both over cyclophosphamide, Lupus, and over mycophenolate. So
yes.
Great. So why don't we move on just to finish out this session of the Lupus Forum? Let's just put a plug in. Maria and I had the honor of working in the ACR guideline group to formulate the new guidelines that were debuted, if I can use that word, the American College of Rheumatology meeting in Washington this past fall. And they're under review right now for the ACR journal, Arthritis and Rheumatology, and this will hopefully be coming out in the not too distant future. But what we're showing here is really a lupus nephritis overview slide. And the idea of this is, I wanted to bring this slide forward because one of the unique aspects of this guideline compared to the other existing guidelines on lupus nephritis is that for the first time, we as a community are recommending triple immunosuppressive therapy for our patients. And Maria, we've had a little back and forth on how to call this therapy, and the idea called triple is hard. So what does triple mean to you?
Okay, that's a great question. And as Brad said, we had a lot of discussion in our guidelines meetings. What are we going to call this so we can make this kind of easy to understand, easy to remember, and allow people to apply this to the practice. So we chose this term. And what this means to me is triple therapy, meaning the first therapy are glucocorticoids. Now, we all want to get to someday, right, Brad, where we don't have to use glucocorticoids because we hate to use glucocorticoids. But as of today, we are still stuck with them, right? Because they are the fastest acting anti-inflammatory immunosuppressive. We need to shut down that exuberant inflammation happening in the kidney to prevent ongoing damage. So the first of the triple therapies, the first element is going to be the glucocorticoids. And then we are adding 2 additional immunosuppressive / targeted therapies. That's the way I look at it. And so therefore, in broad strokes, it's going to be glucocorticoids and either a belimumab-based regimen or a calcineurin inhibitor-based regimen. Everybody across the board, as shown in this diagram that you're showing here, Brad, everybody should be getting hydroxychloroquine as a background therapy. So that's not part of this. And everybody should be getting a nephroprotective agent, such as an inhibitor of the renin-angiotensin-aldosterone system. So we have that listed here on the slide as well. And then the overarching question, which we can talk about in broad strokes, is we have several triple immunosuppressive regimens that one can use. And then the question is, how do you choose which regimen for which patient?
Yeah. So as Maria said, the triple therapies have different combinations. And one of the combinations will be a calcineurin inhibitor plus glucocorticoid plus mycophenolate. And the reason that we said that in that way is because that was the way the trial was done, and there was not a background arm with low dose cyclophosphamide. On the other hand, you could choose a belimumab-based triple therapy, which would be glucocorticoid plus belimumab plus mycophenolate or urolupus cyclophosphamide. And we do have data for both of those background therapies. And, one of the things I want to emphasize, which we discussed quite a bit, is these are not mandates to the lupus community. These are starting points, and you really need to look at your patient and decide which of these might be better. Now, that doesn't mean we abandon everyone and say, just take a guess as to which one of these triple therapies might be important for your patient. We do provide some guidance based on the evidence we have from the primary trials and also post hoc analyses of these trials. And so I think the guideline is quite well done. So it can give you sort of ideas of how to approach your individual patient. But of course, I think, Maria, you'd agree with me. You're going to start something and then you're going to watch carefully. And you
Yes.
still want to have the metrics that you so elegantly put out into the literature several years ago. You still want to see a decline in
Yes.
proteinuria by 2 to 3 months to know that you're on the right track, right?
Absolutely, absolutely. So this is a starting point, and then our patients have to be monitored very carefully to demonstrate improvement. And if an improvement is not happening or worsening is happening,
Yeah.
then we have to switch gears,
Yes.
right? Absolutely. And we can switch gears by switching to a different, perhaps triple immunosuppressive therapy. Perhaps if patients really are not doing well, we can look for experimental therapies, clinical trials. So a lot, and we talk about all these options in the guidelines, which hopefully will be published in the not too distant future. But at least for those of you who are listening, you can listen to the recording of our session at the American College of Rheumatology Convergence, as Brad said last fall, to kind of get a high level overview. But I agree, this is constantly monitoring our patients, making tweaks, making sure they're going in the right direction. But at least this is a starting point, and this is very different. Wouldn't you say, Brad, that I think this is significantly different than, for example, the 2023 updated EULAR recommendations, and even the 2024 KDIGO, where the triple immunosuppressive therapy regimens were kind of put on the same line, right? That you could
Yeah.
choose triple, you could do traditional. And I think what we did with the ACR guidelines was try to take it perhaps one step further and saying, if you have the opportunities to use these agents, and we also are aware that in some parts of the world, these particular medications might not be available. But if you have the ability to use these medications where you practice, the recommendation is to start with the triple therapy.
Yeah, absolutely. I think we have to be cognizant that people around the world will use these recommendations, and they may not everyone's going to have access to all the new therapies at any given time. Now, hopefully that's going to change and we're going to be able to make these therapies available to everyone. But that doesn't mean that if you don't have access to some of these newer medications, that the dual therapies might not serve you well. And I'll go back to your article
Right.
where the efficacy of the dual therapies, yes, they were less than looking at voclosporin, but on the other hand, they weren't that bad.
Right.
And so I think this is really a way for us to allow folks to, you know, see what maybe the best therapy could be, but not to make anyone feel bad that they may not have access to that, and their patients can still do very well with active involvement of the physician and patient working together to
Yes.
optimize their treatment.
Exactly. And then maybe one last comment to make. We emphasized the theme in these guidelines of glucocorticoid lowering, right, Brad? And we spent a lot of time looking at the literature and trying to understand what are the data that support various doses of glucocorticoids that we could be using, especially at the beginning of treatment. And for those of you who look at these guidelines, you will see that the recommendation that we give, and this is very consistent with what EULAR and KDIGO have also recommended, was starting with IV pulse methylprednisolone, but then starting at a lower oral dose of glucocorticoid. And the dose that we are recommending is around 0.5 mg per kg per day with a maximum of 40 milligrams. And so that's not specified directly in this overarching diagram that you see here, but just to keep that in mind, that that's another theme that we tackled, is how do we think about the use of glucocorticoids? What is the appropriate dose? And then what we do have listed here on this slide is to make sure that you continue to taper that glucocorticoid dose with a target of less than equal to 5 milligrams a day, preferably off if you're able to, by 6 months, and preferably earlier than that, but we give that window of 6 months. And just as I think Brad made the wonderful comment that at every visit, after you start treatment, often we see our patients, right, with active lupus nephritis monthly, because things change in the beginning. Not only are we monitoring for improvement, we're trying to decide, do we have the right regimen, but we're also continually asking ourselves, can we get that glucocorticoid dose down? Because that is the medication that's most associated with a variety of toxicities, both in the short term in terms of infections and others in psychiatric side effects, but also, as Brad so nicely stated, it's the cumulative dose over time. And so can we continue to get those steroids down while we are monitoring our patients for improvement in their LN?
And I'll just add to that to emphasize, I mean, we have to remember why we're using the glucocorticoid. We're primarily using the glucocorticoid because of its anti-inflammatory effect that occurs right now. It's our best anti-inflammatory medication. And so when you think about dosing with the intravenous, I believe the intravenous buys us a lot of time and allows us to have a lower oral dose going forward. I think that was very clear from the Voclosporin data. The other thing to remember is we're also not advocating necessarily giving 3 1-gram pulses right at the beginning. Right? Because I think what I like to do, and yes, I'm a nephrologist, but everyone should look at the kidney biopsies of their patients. I try to assess the inflammatory profile of the kidney and then decide how much intravenous I'm going to give. And that helps me judge whether I'm going to give 1 gram or maybe 1.5 grams. Very seldom these days am I using up to 3 grams unless the patient has perhaps an RPGN with significant inflammation and damage, inflammatory damage to the kidney. So I think that's all we have time for today, right?
I think that's great. No, thank you. Thank you so much, Brad. And I agree. I think we've covered a lot of ground here. And I want to thank all of you for listening to this session. You can find the slide decks for these papers at lupusforum.com. The Lupus Forum is free to access. All of our content is free to download. And don't forget to register for updates on the Lupus Forum. You'll receive email updates when new content is made available. And you can also follow us at Lupus Forum, all one word, on Twitter and LinkedIn. Thank you all again for joining us, and see you next time.
Bye, everyone.
Bye-bye.